We are officially recording. So please do participate. It's very it's not a webinar. It's really open to everybody. Free discussion. Now I do want to do one thing before we start.
Legal. Start era menor.
Second, let me see. There we go. Okay, so far, can you all see the screen? Yes?
Yes.
Okay. So far, we have these presentations lined up. Couple of cases from Eytan and myself as well. So we have good lineup. If anybody else has anything, let us know. I also wanted to show you all this, right? I don't know if you're aware, but our Banana in-person, this is an in-person course at NYU, is on. The registration is open. It's on October 14 to 16, so it's right after WFITN in New York. About 3 days course. There's more information on the Banana page, on the front page of Neuroangio and the syllabus. So if you just go to neuroangio.org, you'll see on the front page, there'll be a link to information, registration. And so we're obviously super excited about it. If there's any questions about the course, you can email me or ask here. Okay. Yeah. Should we go ahead and get started?
Yeah.
Yes. Okay. Okay. So here, basically what we want to talk about is this entity. And this is what the discussion is. Like, what are these things? Are they a separate, distinct entity, or is it on the spectrum of what basically is, as we all know, when we talk about AVMs or we talk about dural fistulas, we have obviously pure fistulas, pure AVMs, but it's well known that some AVMs have dural supply, some fistulas have PL supply, and so all of that is well known. And so the question is, though, sometimes we seemingly, just by imaging, if we look at the angioarchitecture of these things, we run into what looks like maybe something more complicated than that. Like there is something that seems like it legitimately shares features of both fistula and AVM. And so we have that's kind of what the idea was, to discuss this thing. And so I wanted to open up with this case here that came to us a while back, a few years ago. This patient presented with this hemorrhage, as you can see, sort of left upper cerebellum. And we have a CTA. There's obviously some sort of shunt over here. Here's the MRI. And so when you look at the angiogram, so we'll spend a few minutes to unpack the angiogram. The right side, there's a little bit of supply from somewhere, but there's more coming from the left. You see that, if you see on the left ICA, there is supply to the back area here. That's the marginal tentorial arcade artery. In this case, here's the left external injection. And so if you look at this alone, right, you're going to say, okay, here's a, dural fistula somewhere maybe in the back of the tentorium cerebelli. You see the usual suspects, Peter squamosal branch, occipital artery. The drainage is into the superior Vermean vein, right? So that's important here. It looks like there's some kind of vein here, maybe just related to the tentorium, going medially, and then the superior Vermean vein, and then into the straight sinus. Now here's the vert injection. And so here where things get kind of a little bit interesting, because it looks like obviously there's a lot of supply. Now some of it is going to come through this posterior meningeal artery or the artery that, of the back here. So you know there is that, but there's a lot that seems to be coming from something, either PCA, you know, somewhere from the vert. And so if you put them here, they are sort of side by side, and you can see them. You can see the contributions. They obviously share a vein. So this is this vein here. You only see in the injection of the dural component, but this kind of like the one that the main one that's probably under the tentorium that's coming into the superior vermian vein is shared. Now, when we get into these things, I think this is where like really imaging, like DYNA, cross-sectional or whatever you want to call it, cone beam CT imaging becomes super important, right? When we look at this and we do separate injections, so on top there are injections
Like one of the head.
vert, and then the bottom there's injection of the ECA. Okay. Now, if you want to unpack that, what you want to do is look at them together and analyze that. So I think that's where it becomes critical. So let's look at this. So this is just MIP images of the external injection, and where you can see the relationship between the supply, this kind of proximal portion of the vein, right? So here's the superior vermian vein, but you see that there is obviously like an admixture of something. There's something else that's coming into this vein that's unapacified that we're not injecting from here. And so here's the injection of the vert. And you see this, you know, that's what we need to discuss. Is this like a nidus? You know, that there's a bunch of vessels here coming into the superior vermian vein as well. Now we confuse that. And so here, like, it's nice. I think this actually adds value when we look at how this is. And so if you fuse these two images, what you see is in the white is the contribution of the external, in the red of the vert injection. And so you can see how there is some vein that's already apacifying a little bit more distally, if you will, right, like further away from the heart. So this is the more distal part of the vein that's in white. Now this is this nidiform component arterially. And then you see the vein, the more proximal part of the vein being orange, if you will. So that's the admixture of the two sources of inflow into this vein. This is the coronal view. Now you could also do this as a movie. So I think like we can unpack this and like look at it, but I think here it actually shows it to probably the most advantage. You see here's the component of the ECA, and now you start getting the contribution of the PL or AVM part of this, and then here they are mixed in orange. Okay, and then that's the coronal thing. So now let's stop here. Maybe we could talk a little bit about what we're seeing, like what do we think about this? Go back, look at it some more. Any comments, any thoughts?
Do you understand which part ruptured?
No. Except to say that we didn't see like a perinatal aneurysm on the PL or vert, you know, SCA pica contributions.
Mm-hmm.
Well, I think we can all agree that it needs to be fixed somehow, given its ruptured state. And I guess the question is whether this is a PL AVM with dural supply or a true AVM with dural supply. Does it make a difference in how you're going to treat it?
Okay.
Well, yes, right? Because, you know, I think when you deal with a dural fistula, I think you're much safer going transvenous. Obviously you can go transvenous for an AVM too, but when you go transvenous, it's important if you think it's a dural fistula or an AVM. So making that distinction is going to make you approach the lesion in a different way, even if you go through the same route.
Now,
Yeah, I'm inclined to that it does make a difference, and for that reason.
so now if we were to let's for argument's sake forget the component of the vert supply. Let's focus on the ECA. Where do we think this shunt is? Like what we would have called this dural fistula if it were just a dural fistula purely.
Can you go back to that ECA?
Yeah, let's go back. Okay, so here's on the left is just the lateral injection. Here you have the frontal and the lateral.
Tentorial. It doesn't seem midline, right? So it's not a falcine.
It's off midline. It doesn't drain into a sinus, like a named sinus, in the way that we like I don't know, transverse sinus or straight sinus. It drains into some cerebellar vein, right? So we would have like the NYU way is to call it a tentorial fistula, right? I think probably a lot of us would call it that, right? Like it's dural, it's draining. Like we can argue about what is the connection between this vein and the tentorium. Like obviously a lot of, as you know, most like there's a ton of the tentorial sinuses, right? A lot of the superior cerebellar veins, they drain into a tentorial sinus before they join a named sinus. That's the rule. That's not the exception. Like some 80% or more of them
Would
drain
you
into a
agree?
tentorial sinus first.
Would you agree here to call it dural fistula with an important pile recruitment
Recording in progress.
and from the posterior circulation?
That's the whole discussion, I think. Is it like a dural fistula? Is it the thing that intrigued me about this case is that it seems like that everything was centered on the vein. Whatever we call it, like imaging wise, there's a vein that receives inflow from a dural component and from some peel or whatever component. They seem to be separated in space a little bit, the dural being slightly more distal, but the convergence is on a single vein.
Max, I think for the purpose of discussion, it would be great for me to show my case now, because it's exactly the same point, in a illustrated in a different way, but it's exactly the same point.
Is that the common thing for these mixed like fistulas, is that it's a cortical venous drain? Like by definition, it cannot be a dural vein.
Not necessarily. All the lesions that are at the petrous apex have deep veins, and these may have a supply from dural, but also from pile arteries. So I wouldn't say cortex, because the same problem is at the level of the petrous apex at the protocerebellar angle.
Or I guess I mean like veins that are sitting in the arachnoid space they're not covered by dura. Maybe that's a better way to say it.
Yes, agree.
All right, let me show this case because it's exactly the same point, maybe a little easier to understand because of the anatomy. This is a woman presenting with this lesion that, it looks really like adjacent to the dura supply. You look at how large middle meningeal artery. I really thought this was a dural fistula, as you're going to see the rest of the case, but here it is, the large middle meningeal artery with this cortical venous drainage. Right CCA injection, and you clearly see the supply from the occipital artery, transosseous branches, a large middle meningeal artery with this vein of Labbe retrograde, like retrograde the flow, that mostly drains through like two veins, these anterior frontal and this parietal vein, but there's also this a smaller anastomotic parietal vein here. Right ICA injection, same view. We see some more shunt in the same area, more or less, supplied by this sort of like temporal branch of the MCA. And the outflow, you see, it's in the same kind of location. Preferentially goes to that smaller parietal vein, but you know, a little also to the rest of the vein that we saw before. Right distal external carotid artery injection. And we see better the shunt, again, like the supply from the middle meningeal artery. Now here you start understanding that there's something a little odd because, you know, you see a little inflow, for example, here, but it's really like putting everything side by side that we understand what's going on here. So this is the common, external, and internal. And when we look at this in detail, like we can notice how the inflow of the this is the dural component with the venous outflow here, but the inflow of the supply from the MCA is really distal to the same venous outflow of the dural AV fistula, but it's not in the same location. To put this into, to look at this into cross-section, unfortunately, the dyna was not that well centered, but this is the dural component. And this here is the PL component. And to put this into a graph, sorry, this is like in cross-section, the same thing. Even on the cross-sectional imaging, before I was able to see that. To put this into a graph, essentially we have this situation. There is a fistulous component on the dura. There is a venous outflow through like a cortical vein, a subarachnoid vein, as you know, it's in the subarachnoid space. Then we have a shunt on the PL, or like in the brain, that drains through the same vein. So this is graphically what we're dealing with in this particular case. And here I will stop because Max, I interrupted just to show like another case, which is like shows the same concept. Like, and you know, I think I don't know what kind of argument we can make about this being a different than how I explained it, but I would be happy to hear different opinions of what are we dealing with here.
So it's, I mean, it does seem similar, right? Like you have one vein that receives different components along its length. Does everyone, like for everyone in the session, like that's the commonality between the two cases?
Definitely, and my case is very similar to yours, Eytan's, even maybe a little even more pronounced as far as
David,
the.
you want to show?
I can sure, yeah, I can show that. Let's see. I just if you can enable.
Okay, maybe oh, you know what? Hold on one second. Make sure. Okay.
Well, I have to stop sharing.
Yes, I think you should be able to show now.
Let's see. So this was a 52-year-old who presented with a seizure, no other medical history. So very similar to Eytan's, just on the other side, there's this, what looks like a nidus, but it seems to be on the left side with like severe cortical venous hypertension. What is interesting is the nidus component seems to be kind of inside the pictorial fold. You see right there. It seems almost like it's intradural nidus. This was the MRA. Just again showing the dilated veins and the what looked like a nidal component. This is the ICA run showing a mix of dural supply as well as peel supply from the inferior division MCA. And it seems like that there are separate components as to where they connect along this venous system. This is the ECA. Again, confirming additional dural supply. I don't know why it's looking all blurry. But, you know, significant occipital meningeal, middle meningeal supply durally, as well as there was no vert supply, and then no contralateral supply. But there was some, you know, contralateral dural supply from ascending pharyngeal and occipital. So this one, to me, looks very similar to Eytan's case, just on the other side. And I'll stop there before doing any.
So Ali Malek is you know asking, are we thinking that the AVM precedes the dural AVF? A venous thrombosis developed and that evolved to a dural AVF secondarily? If not, what do we think is the etiology of this? I feel free to unmute yourself and you know like explain this hypothesis, which is interesting, right? Okay, you have an AVM with a venous outflow that causes some thrombosis, and then on that thrombosis, the dural AVF develops. I guess that's one way we can interpret it. I was, in my mind, I was more like thinking the other way around. You have a dural AV fistula with some venous outflow. And that venous outflow, for some reason that, you know, I wish someone can tell me why could that be, but sort of like promotes angiogenesis and formation of an AVM on the way.
I agree with you, Eytan. Like, you know, to me, it seems more like, at least in our cases, the dural fistula component is the main problem. And then there's peel recruitment, maybe because of the arterialized vein that gets enlarged and somehow has some sort of local attraction to that. But, you know, it seems like the major pathology in both of our cases where it was within the dura. But
I think one of the reasons I was thinking in that sequence was simply that if this were predominantly somehow an aberration of flow, that when we see these, we'd see more nidal aneurysms and more characteristics of significant flow abnormalities. And a lot of the dural AV fistulas that we see that are isolated, we do think they're, you know, post-traumatic, post-thrombotic, and AVMs could potentially have some kind of thrombotic component that then triggers these. It's just not, these are rare when you see both, but they're not that rare. And so I think that whatever the mechanism is, there is probably a consistent mechanism. I just don't know what it is. That was just a hypothesis, so not sure.
No, but that's good. And I mean, when you say these are not that rare, would like to distinguish the scenarios. You know, the fact to have an AVM with additional dural supply, right? Or having a dural fistula with some PL supply is very common. I agree with you. But having this situation where you have two like lesions like that, both drains in the same vein, but separate lesions, I think this is much more rare.
I agree. But like you said, the combination is not that uncommon. This, where there's some kind of separation in space, is much less common. But we really don't see it very often where they're not in the same vascular territory, right? So you don't see an AVM on one side with a dural AV fistula on the other. So that you would say, well, this is an underlying predisposition towards it because of a genetic abnormality or a vascular abnormality. Or so again, when I say it's not that rare, I agree, they're much less common, but we probably all see these, you know, at least once or twice a year, right? I mean, they're not so rare that every time you see one, you want to write a case report. They're rare in that every time that we see one, we're like, wow, I haven't seen one of these in a long time. So I just think that my hypothesis was that there's a uniform mechanism that's triggering this. And I was just trying to figure out, because I don't know that I've seen anything ever written in the literature or heard anybody say, well, I had a patient that had an AVM that I was just following, and we follow a lot of AVMs, that then developed a dural AV fistula afterwards. And most dural AV fistulas, once they become identified, we tend to be more aggressive in treating them because, well, we are. And so that's why a dural AV fistula, we don't have scenarios where we've watched a dural AV fistula for a period of time and then an AVM developed afterwards. But with all the AVMs that we're just watching, if that was the preceding variable, then shouldn't we see in our cohort that we have these AVMs that we've been following over years, and then they developed a dural AV fistula?
I think the cases that have been presented both by Eytan and Maksim are amazing, but maybe it's because you looked so much into the details, how the veins are different. I'm not sure that we put in so much efforts usually to look how the vein is. It's just a vein. Ali, you showed in your case that presumably the shunts are alongside the vein, but in fact, we're not sure. If you have, maybe you can show a bit later when you put a microcatheter selectively in the branches of the MCA, we can see if the shunts are not at the origin of the vein, but later on. But Eytan case is really amazing because we can see that the drainage from the MCA goes to a little vein draining dorsally, whereas the main vein of the dural fistula drains ventrally. So that difference is not, I don't think, so frequent to be seen, but I'm not sure whether we put so much effort in looking at this.
There is a comment by Vikrant about this. I don't know if everybody sees the comment, but and feel free to unmute and talk. But essentially, what they're saying is that it is known that increasing venous perfusion pressure causes ischemia in surrounding brain tissue, which may lead to the formation of new AV shunt, maybe a cause of dural AVF. And he's saying that these were classified by Newton et al. As mixed PL dural AVM in 1969. I mean, when, this is what I showed at least, but I think what Max and David also showed, these are not really mixed PL dural AVM because, again, we showed that these are in different spots. So it's not the same malformation that has supply from both PIA and dura. This is different than what you're mentioning there. But again, feel free to unmute and like expand your argument.
And there's also when we talk about, say, AV fistulas with PL supply, right? There's also a further distinction to be made. Sometimes the PL supply, and that, like Timo has talked about that, like, is it like sometimes it's there's pyodural anastomoses like Davidoff and Schachter or Wolfschlager artery that are remote from the fistula, from the AVM, from the dural fistula, right? And they just happen to like be another source of dural supply through the PIA. That's different. That's not what we're talking about. If sometimes there is more sort of regional PL contribution to a dural shunt, but they all seem to be contributing to the same spot, the same anatomical location. And the cases that we are showing, I think the unique thing about them, and I do think that they're quite uncommon, is that the shunts are anatomically separate. What unites them is the vein, that they're coming into the same vein. And to me, that's what's intriguing. And how that forms which is the chicken, which is the egg, I don't know. Personally, I feel like probably the dural fistula comes first. Do we know? Obviously we can't prove it, but it seems like that would be more likely. is the point of the junction of the dural proximal or distal to the junction of the AVM. So it seems like maybe a connection is unstable or something. In our cases, it looks like the dural component is more distal. Right? Like any maybe other cases, no?
I guess that this may be variable, but at least it's very important to analyze because it changes completely the strategy. And we were considering should we go venous or not? I mean, usually in the dural fistula, you just need to occlude the origin of the vein and you don't care so much of the rest. If you have some pile supply, you need to get the embolic agent getting retrogradely to the more distal shunts.
Absolutely. And like the cases we are showing also, they're not draining into a named sinus exactly. So like how to get like a transvenous approach, you have to go through like some cortical veins if that's going to be the treatment, right? How to get to that. And also that, so many questions, like it brings the question of like, say we have like quote unquote regular, like maybe less complex dural fistula that has some PL contribution. Some people, some groups advocate closing those PL vessels because they're at increased risk of hemorrhage potentially. That's the claim, is that if we close them, they behave maybe as an AVM might, where we don't close the arteries, they might be more fragile. Others would say, no, we can go just close the sinus or whatever. We don't have to necessarily do something extra for them. So that's another question.
I mean, as soon as you got a couple of bleedings, when the pile supply is what remains after occluding the rest of the fistula, it's difficult not to consider occluding the pile stuff.
The pile supply may be difficult to access transarterially, like sometimes. With your experience, probably transvenously, maybe,
Well, I think the question is, can you just take the vein, or do you need to invade that peel connection or not? And because that, is taking the vein enough for this? And at least in my case, and we'll get to treatments at some point, but and there was no hemorrhage, but maybe I just got lucky. So,
well, do you want to let's maybe we'll go on, we'll show the treatment phases. Let's do that.
So, okay, go ahead.
Want me to go? I guess I can
Yeah,
go.
go ahead.
Since I'm on call, and you never know. All right. So again, there are obviously a number of different treatment options that we were considering, surgical versus endovascular, and then if endovascular, whether to do it transarterial, transvenous in a single or multi-stage fashion. This was the, major arterial inflow to the dural part. And so we decided to just go with what was easy first and go through that MMA branch with a Scepter Mini and just inject as much onyx as we could, I think, until we ran out of onyx in our angio suite. And we got like a really nice onyx cast into the malformation component and pretty deep into the vein, but not quite far enough actually to get the entire peel supply. And I'll show you how that looked on the ICA injection afterwards. But you can see that on the ICA here that we were still getting inflow into the more what we call proximal vein, and still having pretty significant cortical venous reflux. And if we look kind of closer in at where this was connecting, it was, really in a very cortical portion of the vein where I had gotten some onyx penetration, but not complete. And so I wasn't able to push through any further though from my catheter position. And so decided to, and then here's like again, a Dynascan just showing kind of where the onyx is and compared to where the peel component is, which is, along the temporal lobe there. So, and we still had some now like a dural component that looked to be in a totally separate area, kind of in the deep vein that weren't necessarily seeing on the initial injections. And so I had to decide whether to keep going or stage it. And given that we did a pretty large injection, and there was already considerable kind of change in flow dynamics, given the kind of stasis in the veins, I decided to stop and put on heparin. 72 hours after the procedure, he had a second seizure. And what we see is what's looking like some either cortical venous thrombosis in those veins or just slow flow. There was no stroke or hemorrhage with that, and we just converted him to AC and decided to wait a little bit before doing the second stage. He was neurologically intact, though, throughout this. He did get an MRI just to try to figure out whether those veins were thrombosed or just sluggishly filling. And I don't think they fully thrombose, otherwise he probably would have had a lot more symptoms. And we were able to get him through that stage to bring him back for a second stage, where my plan was to go transvenous through this cortical vein. And you can see that there were some changes in between the two images. Just pause this stuff so you can see. So there was already considerable kind of slowing down of the shunt from the initial post-procedure to the follow-up. And that really the major supply now was coming from this peel component, and then draining up into this cortical vein. And that deep stuff was actually going away. And then this is the ECA run. Just showing that, most of the dural supply wound up thrombosing by itself. So I did a, Dynascan to fully evaluate kind of where were the inflow components from the MCA to the vein, to figure out where along the vein I could take without potentially compromising, what would be normal venous drainage from the brain itself. And so I decided that, this is where the onyx cast is. And if we got up to this part before it, the kind of this, where it connects to the anterior and superior venous supply, that I think that would be able to achieve a cure. And so this is kind of the target, the partially onyx vein, and just getting it up to that junctional point. So we went transvenous. I have, I think, a track star in, and I believe it's a scepter balloon. And I used it to kind of bounce off my microcatheter, given that these cortical veins tend to really make U-turns as they enter the superior sagittal sinus. And so I was able to use that balloon to help deflect the microcatheter into the vein. And be able to get it to come around down that cortical vein. And I was using, I believe, a headway duo inside the the cortical vein, and the plan was actually just to coil off that part. So we got in there and coiled it. Like up along the most, where the onyx cast kind of stopped, and where it was kind of missing some of that inferior aspect of the vein. So this was after coiling, looking pretty good. No obvious shunting anymore. Still a little bit sluggish flow in the cortical veins, but given where we started, it looked pretty good. The ECAs also look good now, with no obvious shunting there. So he was discharged, neuro intact with no further issues. At 3 months, early follow-up, he had no issues. I would say for these very high flow fistulas, the one of the morals of the story is AC early and often, because it's a dramatic change to the flow dynamics to shut down a fistula that's such high flow. So he's actually now 1 year out, and this was his 1 year follow-up MRI. Again, showing no stroke. There is much improvement in the size of the cortical veins, and the general venous congestion of the brain is much improved. And there was some question though, like, was there any residual? And so we took him to angio just to check. This is 1 year follow-up, and there is this kind of, there may be a small dural component here along the MHT. I don't know if you see that. But as far as the actual peel supply and the general brain congestion, it's seemingly much improved compared to a year ago. ECA looked good as well. And so far he's doing well, and I think we're going to keep watching that and before doing anything else. And since it's the French Open finals right now, just so you know, it's in the 5th set. This is the sign entering the Wimbledon stadium. If you can meet triumph and disaster and treat those two imposters just the same, I think this is sage advice for anyone who's doing neurovascular. But thanks, Eytan and Max, for letting me share my case.
Excellent.
Thanks, David. That's a great case and a lot to talk about, right? Okay, any comments? Great case treatment, right? So I guess I have a couple of questions. One would be like, originally seems like when you went for the second stage to coil it, had you been able to push the onyx further in, that was the original goal, right?
That was the original goal, just to try to take it down in one.
Take it down from the vein. Now that wouldn't be the sort of the dogma, if you think this is an AVM, is not to take the vein without taking the arteries.
Yeah.
You were thinking something different about this?
I mean, yeah, I guess my feeling was that this was primarily a dural fistula, and that the dogma around that, which is taking the vein, is the best approach, and the peel component was, I guess, part of the same process that was going on. And maybe I was foolish to think that, though, and that is a potentially a dangerous thing to do.
You did anything, he was not anticoagulated when you brought him back for the second stage, or he still was?
He still was. He was on AC. Yeah.
Do you hold them for the treatment, or you continue?
I think I was continuing it.
But it wasn't like, it doesn't sound like this was a major thing in your mind, like
Yeah,
as
no,
far
I
as
wasn't
how
even
to do it.
worried about hemorrhage for whatever reason. And I guess, you know, if I couldn't do it endovascular, the plan was just surgery and to disconnect it surgically.
It's very close, right? It's like on the
Superficial,
surface.
it would have been a fairly straightforward operation.
Mm-hmm.
Yeah.
Do you
So
remember which wire you used?
I was using just regular Synchro 2 soft microwire. Yeah.
Okay. Any other questions or comments?
I would say it was a very nice procedure, and the fact to stage was certainly an advantage because the vein was smaller, so there was less to occlude in the vein and better chance to get it done. Probably better than trying to continue to push Onyx so far away. So very nice.
Thanks. I think, you know, and you know, yeah, I don't know if there's a lesson to learn or not, but I do think that it can be safe to go transvenous without having to penetrate the PL arteries and have a hemorrhagic complication. I don't know if, again, that you can say that for every case, but at least in this case, I was able to get away with it.
I mean,
Anything
I
else
guess
you
that's
have
part of
for
the
you?
discussion is like, is this a different entity? Right? It's rare. If it is, like, do we have to follow the dogma or not? For these ones, and like be more OCD about taking the arterial supply.
I mean, in my case, I follow the dogma. I mean, I don't know what did you do?
But the dogma is also don't have complications. I mean, if the
Yes.
arteries, the pile arteries are too small, it will not be good. So that was here good strategy.
Yeah, I didn't feel like I had a transarterial approach for the remaining fistula, and I thought it would be way too risky, given how small the feeders were. And so for me, the only endovascular option was transvenous, and if it didn't work, it would be surgery.
Yeah, the variation of the endovascular option would be to use to basically use liquid to push into the PO supply somehow, whatever way, pressure cooker or some other way to do it versus surgery. Eytan, do you have continuation of your presentation?
Yeah, I can show how we treated a little more with the dogma, as you said. Let me go back here. I mean, I don't know if there was someone not connected, but essentially the concept here, we have a dural fistula and a separate PL AVM along the same venous outflow. So when I brought the patient in, I was ready to treat the fistula. I didn't know about this. So what I decided on right there and then, it's to treat only the dural component without penetrating the glue or the onyx all the way to the inflow of the AVM that, by the way, was here. So I did a pressure cooker technique to fill all the dural component, but trying to stop with the glue at this level. And I was able to, as you see, we got the proximal vein, but not going to where we know the AVM would have gone, and it seemed like the dural component was gone and the AVM component was left there. You see now clearly how now, because there's no inflow from the vein from the fistula anymore, now the AVM utilizes both routes of that venous outflow. The plan at that stage was to bring back, we discussed with Ares and to bring back for another angio and embolization of the AVM before the surgery. That's what happened. So a few months later comes back, and something, I think it was 3-4 months later, for insurance problem, you know, we were planning to come much earlier, but happened quite a few months had to pass. So now what you see with this follow-up is that now there is a recurrence that, you know, probably because I didn't close this branch, which was probably a mistake, but there is a little recurrence of the fistulus part that, you know, easily, like, you know, we got in and we closed it again. And then we concentrated on the PL component. And here, this is the catheterization with a microcatheter with, we embolize this part. And, you know, we even if we didn't have good penetration on the vein, it seemed like, you know, nothing was left. Regardless, went for surgery, because that's, you know, what we tend to do, unless we're very 100% sure that we got completely the AVM. And this is the 1-year follow-up. You see, like, complete cure. Like, this is the ICA. This is a common carotid artery injection. So complete, you know, resolution of the issue. So essentially, to summarize how we approach this: treat the dural fistula without involving the venous outflow at the level of the PL component. Bring back, because very superficial, bring back for surgery, resection, and we obtained a cure. You know, different way to how do you say, to shave a cat? How do you say?
Skin the cat.
In the cat.
Yes.
Eytan,
Yes.
just a comment, beautiful case, but you didn't follow the dogma.
Okay, what is the dogma?
Because for us the dogma is to go first to the PL part of the hybrid malformation, and then to go to the dural one. But
Okay.
that's great.
Okay, but you know, like, how many cases like this have you seen? Not of mixed PL dural AVM, okay, but of separate nidus, like joining into the same vein. So, like, when you say, when I said the dogma, I meant the dogma about the treatment of AVM, which, you know, is pre-op angio for superficial, pre-op maybe angioembo, and followed by surgery. That's what I meant by the dogma, rather than, you know, try to treat it, you know, like David Altschul did, which you know, was very successful and very good.
Yeah.
I think there are too many dogmas.
Yes. Yes.
That's what it is. When you're talking about the same fistula with PL component, like, some people would go for what you're saying, right? Yeah. And it's okay. Any other comments about this? Like, it kind of ended up being similar to what David did, right? Just there was a surgical part, but the sequence of which one to take first was basically kind of similar.
So we both went against the dogma, I guess.
Yes.
We took dural.
I was
Yes, but
conservative.
for both of your cases, you have first at the, I would say, at the origin of the vein, you have the dura, and then later in the course of the vein comes the pile shunts.
Yes.
Maybe later I will show something which is rather different.
Okay.
Okay, so yeah, so let's move on. Let me just finish. I'll show what happened in my case so we can finish that. Let me see here. Right. So basically, to show, and it goes along the same lines. So let me skip. So for the people that joined later, this was basically a kind of on the spectrum, if you will, of what we are showing is we have a peel, we have this was a hemorrhagic case, and here's a ECA injection. So you have a component from the external dural circulation, and then you have a component from the PL circulation. And they are also not, like, it's a little bit more, there's just a little bit, it needs, like, they're a little bit closer in space to each other, and the vein is in the posterior fossa. So basically, it's a similar idea that the white shows the external contribution draining into this vein along, probably on the undersurface of the tentorium, that then drains into the superior vermian vein. And here in red is the admixture of the PL part that's coming into the same vein. And so what we did is, so this was, we also wanted to stage this. And so this is the, like the other, whatever, the dogma spectrum. So we go into the SCA, deposit some glue. So this is like a pre-op. The idea was that we were going to close the dural part, and then we wanted to resect the AVM part or the PL part or whatever. We call that. And so this was a basically like a classic pre-op embo, glue and BCA, like arterial penetration, maybe a little nidal penetration, not reaching the vein, and then coming into the MMA, so the petrous squamosal branch. That's a great place to be, generally, for a lot of them, you know, whatever, dual balloon. This is a septor coming in. And then here we were able to actually navigate. The septor went into the vein by itself. So the hole was big enough to put the septor in. Now, at this point, we had the choice. You could say, okay, could we just like do what we wanted to, like what David was saying, like just push the onyx or whatever, and let's just close it from the vein part, do a transvenous treatment of both, or do we isolate them? Do we stage? So we figured, okay, let's not change the plan. So this cast here, which is like a little bit of coil, so we put some coil in. So we didn't want the onyx to go too far. So we put the coil in to backstop it, put some onyx in, took out the dural component. And then this was the residual of the PL1, and that was resected. And so some fancy images, and this is the post-op from after the resection. There's no shunt. So patient did well as well. So basically, I think the treatment sounds like we were all kind of approaching them in a similar way, maybe thinking or like how to stage it or not, but that's what we did. So any questions or comments on that?
I think in your case, Max, it's very reasonable. You know, that, you know, it's ruptured. You need kind of an early definitive treatment, especially for posterior fossa. So I think the idea or the plan for embo surgery makes a lot of sense.
We have to hold back. Like, do we just like take everything now? Because it's like we're right there in that vein.
You're right there. You could have,
like you're there. Maybe we should, maybe should have done it. I don't know. Maybe should have done it, but yeah, like do we have I mean, surgically, obviously very accessible, you know?
Yeah.
So like, okay. Anything else? Any if not, we keep going. Maybe Rene, you want to, let's keep going with your cases.
Okay. So let me share my screen, which is this here. Okay, so that's a lady I saw 1 year and a half ago with a major history in her past, an AVM known since 35 years. First bleeding was in 88, so at that time 35, now 36 years ago. And a lot of treatments. You know, she had 4 bleedings. I don't have, unfortunately, the original picture how it was. She had a lot of transarterial embolizations in different places, considering the fact that, I mean, 30, 40 years ago, it was already heroic to be able to bring a catheter somewhere and to put some glue. So that she progressively developed a lot of collaterals. She had also 3 times radiosurgery, and she was supposed to have after some embolization surgery, but this did not take place. So here are some pictures of her AVM 20 years ago, where you see that there are a lot of collaterals getting to that vein that is somehow visible. And you see that from the ECA, there is a lot of things which is doable already now. We're almost 20 years after the first embos, so in those patients having some partial treatment by transarterial embolization, specifically with NBCA, there's very often meningeal recruitment. Here is the posterior circulation again. And now 2010, some years later, the collaterals are still there, even more. You see that that vein here is growing. And it's continuing to grow. That's again 2010. And now 2023, that vein just rebled here. That's a spot that just bled. And there are a lot of meningeal arteries, but they've already been embolized in the past, so they're not really well accessible. Here is so ECA, then the ICA, which is not much better. And again, the posterior circulation. So trying to, at some point, maybe venous, but of course too large to start for venous here. So trying to look inside the collaterals, and somehow it was possible to get much more far away than I had expected, taking Marathon and Chikai 10X that arrived here, really at the end of the straight sinus, or at the origin, well close to the falcotentorial region. And from here, I could inject onyx, or rather squid, more diluted so that you can inject more. And these are the before and after. This is after this meningeal injection. And the point is that here you see simultaneously at 3 different stages. I mean, on the left is immediately after embolization, and while waiting, you will see here the outflow with that venous aneurysm going to that direction, then going up the vein and then out through the straight sinus. And you see that 10, 15 minutes later, that venous aneurysm is hardly to be seen anymore. And you see that a bit later on, it starts to be even more worrisome, because, I mean, maybe it's good, but maybe it's bad too, because that venous aneurysm is not to be seen, and most of the dorsal part of the vein is not really seen. So you see that in the meantime here, a catheter has been brought to the vein, but the question is, what's going on here? Is it good or bad? And I was very worried here. I can show you again both, I mean, all 3 images at different stages from the left to the right, where you see here that vein, which drains posteriorly, that you see here coming delayed, and that you see also here very much delayed. So presuming that that vein was going at the level of the venous aneurysm. And by looking at the 6D, so what I call 6D is when you make a rotational angiogram. One is posterior circulation, one is the ECA, and you give a different color code. So orange is the ECA, blue is the posterior circulation. And if we look here, that big thing here is green, so a combination of 2 colors. It's obviously that large venous aneurysm. And if we follow the vein, we can follow the vein here, getting anteriorly, ventrally, reaching that other aneurysm before it goes to the straight sinus. But if we look again around that venous aneurysm here, we may see that the origin is this vein, but this vein here is the blue vein, and the blue vein becomes that orange vein, orange being the ECA. And only in retrospect, I understood what I had done here, which is that because of probably excessive injections through the meningeal circulation, injecting here the orange primary vein, I call this here primary vein, arriving in the main vein. And obviously I was somehow blocking that vein. And this is something which I would say, I'm not really surprised, even if here I had that issue, because quite often in all that AVMs pre-treated where you see an important meningeal recruitment, I have the impression that the meningeal recruitment comes quite distal in the course of the vein. So starting by the meningeal arteries is on one hand very sexy because you got an easy access to do something. But on the other hand, you may compromise the outflow vein distal in this course. And this is what happened here. So here I had no other choice than to be able to find a way to get to the vein. And here you see the catheters in the vein taking some time before it was possible to join that place here. First with the first catheters, then with the second one. And once this was achieved, I could plug here and inject retrogradely to be sure that this would not bleed. But it took me much more time than expected to get to that vein here and to do this part. So that was here, that first treatment. She went well. But okay, then the rest is less interesting. I continued by the veins and finished the AVM, but I'm not sure that this is what we want to see here. So, I mean, I can show that the following vein, the other vein that was done the following time was that one here. This here, that was vein number 2. Again, you can see it because of the matching of the colors that was taken here to get access to the all temporal and occipital compartment fed by the MCA. And when getting there, back in that vein, it was possible to get here that part from the MCA. And a bit later on, there was a third treatment with a very little thing here, but I mean, nothing special. That's here sometime later where the AVM is cured. But here, for me, the take-home message of this is that where meningeal recruitment goes inside the AVM is not necessarily at the origin of the vein. It may be much more distally, and here it could have been a drama if that vein wouldn't have been accessed and when it was when the flow was getting down.
Retrospectively, you think there was a way to like see that before? I mean, there was a mess of vessels there. You know, it looked like, seemed like an impossible forward like understanding, like prospective understanding based on the images you show.
I mean, if you see it in retrospect, then probably it should be possible to see it before. But it would mean to start to go by the veins from the beginning, and it was too large. So I didn't have the guts. But in retrospect, maybe I should have done.
It's a great case, of course. Really fantastic.
Amazing case.
Probably different, right? Different from what the cases that we showed before, right? Like, or is it? Or is it not? Like, is it more like an AVM that long-standing that has like recruitment
That's
from
what
dura because of whatever previous treatments, this and that?
Yeah, I think it's the other side of the spectrum, as in the chicken and egg. This is the AVM that made meningeal recruitment.
So the pattern of, like the relationship between where the AVM is and where the dura is, like Rene, that's the key point in your case, right? And so many, I totally agree. Like, as you know, like so many people, like the first thing is to go external because, as you said, it lures you. It like makes that it's a trap potentially, right?
And somehow it's logical because the vein comes from the deep part, and then at some point goes to the peripheral part of the brain. And when it gets to the peripheral part of the brain, then everything which is piled, which is being recruiting from the dura, joins the vein. So I don't think that you ever see that the dural compartment goes to something deep inside the brain. It must remain at the superficial part. So it's always interesting to compare the venous outflow from the dural compartment and from the cerebral compartment. And there is a mismatch. I mean, for the patient that you all three that were shown before, it was an original lesion that was different. I would say the dural fistula recruiting secondarily pile. And here I would say it was an AVM that secondarily was recruiting dural branches.
Also great to show. I say I have the same impression. But like what you showed, the 6D, I think that's great to show. And like we keep emphasizing that too, like in our cases, like you have to understand these things, and it's about safety, right? It's about safety. To understand them, we have to be able to do this. And I would say that it's probably, I don't know, maybe like we do these things a lot for this kind of imaging. Most modern machines are capable of doing this kind of imaging. And so we keep pushing for that. I think that needs to become the standard of care if we're doing an AVM, to have this sort of analysis or a complex fistula. Because ultimately it leads to better outcomes. I mean, what you did, right? Like obviously for most people, they wouldn't begin to touch this thing, right? But the insights, like once you saw what was happening, that were like, no, this doesn't look good. I have to do something now. That comes from what you were doing, right? So we're preaching to the choir maybe, but for the rest, there's a lot of people watch these Bananaz that after we put them on YouTube. So I think like really need to do this kind of imaging, and I hope for the industry that are watching it.
So you know, from if I can give an advice to the vendors, like this imaging has to be easy to acquire, easy to load, fast to load, like you know, those are the important thing to like be able to expand this and for this to be used more.
That's exactly what I was gonna say. Like, I think, and we're gonna show this in Banana. It's another plug for Banana, like how to process these images, how to do this, but it has to be more user friendly. Like the spin, where you do the spin and you see the angles, how to coil an aneurysm. Maybe it won't be as easy, but it has to be much easier. It has to be.
Really great case. I think for most of us mere mortals, we would have looked at that angiogram and said, "There's no hope for a cure," and to get such an amazing result is, you know, I applaud you. And but I think that's what it takes, right? You need that detailed level of analysis and understanding in order to do that safely. And I, you know, I don't, you know, I don't think everyone's there. Like we're not all there to be able to kind of do it in a way that makes it user friendly for the masses.
I completely agree. But to encourage it again, to put the plug in, like it's sort of like what Kim Nelson talks about when we're embolizing a meningioma. Like he says, okay, like most meningiomas probably you can resect without an embolization. But then there is the one that's either it's a meninge or it's a JNA. It's just you cannot do it. So if you don't know how to embolize like a meningioma period, and then you give you the one that you have to embolize, it's a different story. So the way to do this is to start with the things that we understand and do this and get good at it with simpler things. Like this is like super complex, of course. But if we understand the simpler, we take it more and more. And that's, as a field, I think we have to move that.
No, I agree, right? And that's what's so cool about having all these additional resources and imaging techniques to be able to help understand very complex cases and help make them simpler.
But I think it's a good message to share that taking enough time before starting a case makes sense. To put a microcatheter, many vessels, to do several volume acquisitions, to fuse them, to look at it. The more we understand before, the more we may avoid potential issues.
Yes, the more. Thank you. I mean, it may sound obvious, but it's not. You know, when we see the practice, you know, like is very often, you know, we see problem related to lack of understanding, lack of spending time or lack of enough imaging to understand things before acting. Yes, spend as much time as you can, like, try to understand the detail you can save. Ahmed, are you trying to say something? All right.
Okay, let's see. Hidetsugu, how are you? I think
Good, how are you?
Hidetsugu has a couple of cases. Hello, thank you for joining. I know it's very late.
Yeah, it's
where
2
you
a.m.
are.
in Japan.
Thank you for being with us.
So you can hear me, right?
Yes, it's a little soft. I don't know if you could maybe speak up a little but
Oh,
we
okay,
can hear.
okay. Just a moment, I'll check this setting.
You should be able to share.
Yeah. Okay, now. I'm going to present two cases. They are not in the within the topic of this time, but I'm going to show two dural AV fistulas with troublesome feeders. This is first case, a female patient presented with headache, otherwise neurologically intact. She was discovered to have a vascular lesion on MR, as you can see here. And this is right ECA injection demonstrating a dural fistula in the posterior fossa, which directly drains into the cortical vein here. And this is a lateral view. This is a magnified view. As you can see, this is the ascending pharyngeal artery, neuromeningeal trunk. And this is a branch of occipital artery. This is a neuromeningeal trunk. This is a branch of occipital artery. And if you look at the 3D image, yellow is the ascending pharyngeal artery, and the red is the the branch of the occipital artery. As you can follow, you can see these arteries goes into the jugular foramen to participate in the dural fistula here. And the location of the shunt is here, which is the jugular foramen. And so these are jugular branch. As you can see here, this pattern is mentioned on neuroangio.org, where the jugular foramen supply is not exclusive to occipital ascending pharyngeal artery. It is shared between the two. Sometimes one does it, sometimes another, sometimes both. And this is a right vert injection demonstrating the posterior meningeal artery supplying the shunt. And this is a early phase, and this is a later phase. And this is a lateral view. And this is 3D image. And on coronal image, you can see that the posterior meningeal artery enters the posterior fossa through the foramen magnum, and then supply the fistula. The posterior meningeal artery is known to have supply to the lateral medulla. May have supply to the lateral medulla, and also it may have connection with the pica. So this is another case, posterior meningeal artery originating from the jugular branch of the occipital artery. So if your microcatheter is here, then you can inject tonics or glue or whatever safely if you don't have a reflux up to here. But in this case, I was not sure if I can inject onyx from this point here. So how would you treat? Transarterial? It has risk of lower cranial nerve palsy because they are supplied by the jugular branch, and there is risk of lateral spinal stroke because the shunt was supplied by the posterior meningeal artery. And what about transvenous approach? Of course, it's too tortuous to go close enough to the shunt. So I chose surgery, and I made a craniotomy here. I didn't open the foramen magnum because there is a big occipital sinus, and this is what I saw. This is a cerebellum, and this is a cerebellar convexity, and this is a foramen magnum. This is the right cerebellum, and as you can see, this is a vein, draining vein, which is red. And what I did was to coagulate the vein here, and the shunt was gone on post-op CT angio. He discharged home on POD6 without any neurological deficit. The second case, a male patient present.
Before you go on to the second case, can we unpack?
course.
Can you go back a few slides?
Which one?
Back. Yeah. So here, like, okay, up to here, like, okay, so this is essentially going to the same location, which is the jugular foramen. Go forward one slice. Forward. No, forward. The one. No, like forward. After. Okay, here. So I like the image on the left. I didn't completely understand that. Is that the same case?
No. It's not the same case. This is a different case.
Okay, good.
Hidetsugu, can you the one I wasn't sure if I understood what was the status of the like jugular bulb, jugular vein in that area? Was the brain like draining in there, or what was the
the jugular vein is patent here.
Uh-huh.
I didn't show the normal circulation, but the transverse sigmoid and the jugular valve is patent. It drains into the internal jugular vein.
So basically, the shunt is at the jugular foramen.
Yes.
But the drainage is not into the jugular bulb.
No.
It's into a cortical vein, right?
Yes.
Just for everybody, so everyone like understands that. So because we see that, I think that's important to show too sometimes. Just because the shunt is near a sinus doesn't mean it's going to drain into it.
Right.
I guess one question to ask theoretical is, did it start draining into the sinus and then somehow that got closed and now it's going into the cortical vein or not? It's not important for the treatment purpose, but
that's a good question, I think, and I don't have an answer. But what do you think?
I mean, I don't know. It seems like for the AVMs, and like at least in some of the AVMs, it seems like the logical, like the way when we discover them with seizures or whatever, their location would be such that you would expect the primary drainage to have been not the way that we discover them. Like say it's parasagittal, like next to like the trillard should have been there draining into the SSS, and now it's draining into like 5 other veins because that seems to be closed. So I don't know if that's the same thing plays a role. Like obviously that's how dural fistulas can evolve, when they like drain into the sinus and then the sinus gets closed and then they get higher grade. It's very like
that's possible. I'm not sure, unfortunately.
Any comments on this? Like any questions, comments about the choice of treatment analysis?
I mean, there was a comment, and Rene also agreed on that about AI matter. I don't know who is AI matter, but there is a long course of this posterior meningeal artery which can be accessed and transarterial essential approach with some sort of pressure cooker with a dual lumen balloon or some other way that can cure the fistula maybe. I mean Hidetsugu concern was the supply to the lateral medullary, which I would say, as much as in the book may be described and theoretically can be there, you know, a posterior meningeal that comes from that location, I would be very surprised if it supplies the medulla. You know, anatomically, you know, this very low posterior meningeal origin and going laterally all the way like that, I would be extremely surprised if it supplies the medulla, honestly. I mean, there may be some sort of anastomosis later on, but not a direct supply. That's my comment. So I would say a transarterial approach is certainly something I would have considered.
So if you had
From this branch, not from the ascending, not from the
from this one,
like not from the bad ones, the ascending pharyngeal one.
Well, those were a little more indirect. I mean, if you know, on the image, it seemed like they merge in the region of the jugular foramen and then go a little more forward, a little more forward to the shunt. So that's why I would choose this one. Yeah, here on this image on the right, it seems they merge, and then they go a little more forward to reach the point of shunt. So that's the reason why I would choose this. The branch from the vert, the posterior meningeal proper.
So if you do a pressure cooker technique with the onyx, then I have a fear that onyx would infiltrate into the ascending pharyngeal from the posterior meningeal artery through the dural network.
Yeah, it's certainly. I mean, I agree on that concern and that risk. I mean, it's no question.
I mean, I think we all I agree. The risk, but then I think everyone, like when people watch this, they need to understand that that's the risk. Like the Hidetsugu's analysis, like of the jugular, to understand that first of all, like from the occipital artery that could be supplied at these branches, you know, and you need, again, the cone beam CT, like an anatomy knowledge is key here. They show you that like those branches you're risking like 9, 10, 11 if you go that way. And we can debate about whether the posterior meningeal would have been an acceptable risk. But I would say from the perspective of like cranial nerve issue, the surgical treatment seems like least risky. So I'm kind of like feeling that like I'm sure there are other considerations, surgical ones. Maybe Hidetsugu, can you, like, for the non-surgeons here, could you maybe comment on, like, when you're thinking of doing the surgery in this location, what are your thoughts, considerations as far as risks, like issues to avoid, things to watch out for?
Well, if the location is surgically accessible, then the surgery itself is simple, just coagulate or clip the draining vein, right? So it's simple.
But on the way, like when you're getting, yeah, I think that's important. Like we also have to know, like,
well,
the key here is like you have to know the target. In the vascularly surgically, you know where the target is. The target is the proximal vein. But as you're like to get to that, like probably the most of the risk of the surgery is not when you're there. It's like how to get there safely.
Well, so you mean during craniotomy, there's no risk. Right. I mean, just cut the skull and then open the skull, right?
Okay.
Is that what you mean?
No, I mean, I'm sure there's like infection, like other risks related to the craniotomy in general.
That's possible, or bleeding after, I mean, post-op bleeding, but the risk is quite low, I think.
Okay, any other comments?
Doesn't it look like a condylar vein fistula which did not find the way out and search for a way in?
Yes, I agree. It looks is the location of the coronary fistula. So either that thrombosed or, you know. So meaning, would you try to go blind through where you know the posterior coronary vein? That's also an approach, right? You know, the way that we do with the IPS more often, like try to go blind where we know the IPS is. Can we do the same here, trying from the bulb to get blindly to that fistula the same way?
You mean transvenously?
Yeah.
Transvenously from below, Hidetsugu, not transvenously through this crazy vein.
Right.
But to
That's a
assume
good
like
idea, and I didn't think about it.
Difficult to say how much the wire would go through, and at some point scary also. But if it's in the bone, somehow we may have some range of trying.
Yeah, you're right. You're right. Yeah, I should have tried.
I would add that the value of a microcatheter run is that you may see the fistulous pouch a little bit better. It may have been, it just provides a little bit more information because you would get a better sense of the fistula. And, you know, I think you could probably see that with the cone beam CT that you did too, but, you know, it could give you a better sense of, you know, what the network or the fistula site looks like.
Yeah, and I would go even a step further. Like you can do if you're concerned, like you can do a microcatheter cone beam CT. So go into that posterior meningeal artery and do a microcatheter cone beam CT to make sure, if you're concerned about supply to a brainstem, for example, you can make sure that way.
Right.
Like Max's case, you could just probably, you know, sometimes there's a large enough rent that you can get into the vein, you know, and coil back.
yes, I agree. I think that's the one reason to try with a very small microcatheter, perhaps through this posterior meningeal, you'll get into the vein, possibly. Exactly. Or when you're there, you're gonna have the appetite to maybe try to treat, rightly or rightly or wrongly. But I think I don't know. I think there's something to be said for like, just like we were talking about the previous cases today, that we have to have a strategy. Like whatever the strategy may be different for different people, obviously, depending on how you see things. But like the approach of like, let's just try to get in with the microcatheter, see what we can see, like start pushing the embolic material, that's not the right strategy, right? Like Hidetsugu had a strategy. Like this is the right strategy in that setting. And like stuck to it, you have a good result. That's, I think, is very important.
And microcatheter injection should be done under general anesthesia, right? With an intention to treat that lesion.
You had such a cooperative patient. You have all of these angiogram without general anesthesia. That's like, you'd almost like, if you look at these pictures, which are beautiful, like most people would assume this patient was under anesthesia, perhaps.
No,
but
this patient
yes,
was under local.
Yeah, I mean,
outside Japan is difficult.
Yeah, absolutely. But no, it's like the images quality is fantastic, and you have a lot of like so much information without doing GA. Okay, so now you have a second case, right?
Yes. So this is the second case, a male patient presented with pulsatile tinnitus, and the MRI showed this vascular lesion here. And this is a external carotid artery injection, demonstrating dural fistula at the level of the jugular foramen, supplied by the ascending pharyngeal artery, and also the occipital artery supplies the shunt around the sigmoid sinus. And there is a cortical venous reflex into the vein of Lavi and also the superior petrosal sinus. And this is for the injection, demonstrating this artery here supplies the shunt. And I think this is a PL feeder, and this is a lateral view demonstrating the sigmoid sinus, and this is sigmoid sinus and the internal jugular vein. And on 3D image, I mean 3D angio, you can see the PL feeder pulses down here to the to the jugular foramen, and on MR you can see that this artery runs lateral to the medulla oblongata. This is a venous phase of left ICA and VA injection, demonstrating the transverse sigmoid sinus is no longer used by the brain. So how do you treat this case? The problem here is the PL feeder, as we discussed before. The PL feeder of dural AV fistulas were identified in 11 to 24% of dural fistulas, and they can be culprits of post-embolization, hemorrhage, or stroke. And this case is one of those cases. This is a case of tentorial dural fistula. They embolize the fistula through the posterior meningeal artery with NBCA or glue, and then it bled. So they went into the pica and closed it with the glue. That happens. So how would you treat transarterial embolization of the PL feeder first? But I think it's small and tortuous artery, and there is substantial risk of injuring the artery during navigation, and also there is risk of medullary stroke. And what about transvenous embolization with the with the balloon protecting the sinus, and then injectonics to retrogradely infiltrate into this PL feeder? But I think the risk of lower cranial nerve palsy is unignorable. And if failed to get the PL feeder, then I think it may bleed. What about, so I decided to go for transvenous or transarterial embolization with keeping the PL shunt just open. And this is what I did. So there is a residual shunt here, but there's no longer a cortical venous reflex. And tinnitus was alleviated, and the patient has no neurological deficit. So what would you have done in this case?
Let's go back to maybe some more diagnostic images to see. Okay.
So this is the PL feeder.
Okay, any comments, thoughts?
How is the labet draining on the side now? Is it going anterior or superior?
The vein?
Yeah, just the hemisphere.
The labet, Hidetsugu.
The labet is closed, right? I mean, with the coil here.
No, I mean, just how is the brain draining normally now that side's occluded? Is it going anterior or
No, the other side. I mean the anterior and the contralaterally.
contralateral? Okay.
And basically, what you did is you converted like a higher grade fistula into a low grade, much smaller
Exactly.
fistula. The labet is no longer like took care of the labet reflux, kept some of the fistula open because of a concern of PL, like this PL vessel.
Exactly.
Right. So, I mean, a
Well,
lot of
I could
people.
have closed this shunt with placing coils up to the jugular vein here,
Mhm.
but I don't know if it's safe or not, so I didn't do it.
I think that's the question. We don't know. If you look
Yeah.
at my case, maybe it is safe, but you know, for other cases, maybe it's not, and so I'm not sure we understand the risk.
I mean, even I think we can agree that in this case, that's the biggest risk of this procedure. Like in terms of alleviating, like this is whatever, this is good. The base taken care of. Pulsatile tinnitus. I'm curious, did the pulsatile tinnitus go away completely or is less, but still there?
It's still there, but it's substantial death.
It's a lot less, right? Yeah. You know, our experience too is at the jugular, like at the jugular foramen, like when you go down low,
Mhm.
people are kind of hear these shunts very well. They don't have to be very big to be audible. But as long as it's tolerated.
Where is the outflow now of the fistula? Where does it go?
Just towards the jugular vein, like this.
Okay, so can you finish it up by going through there and continuing the transvenous occlusion?
Well, technically I could, but you know, I thought there is a risk of rupture if I close the PL feeder.
Yeah, I
That's
think
what you mean?
Hidetsugu's concern is that, like Timo shows some of these cases, that if we close the vein, I have a case in the interest of that I could show, but basically,
Okay.
like these PL things have a non-zero rupture risk if we just close the vein, right? Now, what is that in the literature? That risk is what? Like 10%, maybe around that, maybe a little more. Do we know?
Well, I don't know. I don't know. I couldn't find the number of the percentage of the risk of rupture after leaving the PL feeder.
We have one case in amongst, I don't know what the denominator is, among many, but it does happen.
I mean, this PL supply doesn't seem that strong, and you know, there's certainly something, but you know, it doesn't seem to me so prominent that I would be that concerned. You know, when if you jail a microcatheter there, and you know, you can, as you mentioned, as an option, like trying to push, like you're concerned about nerves, you can be very minimalistic about it, you know, just to, you know, help a little the feeling of the artery that supply. I think the risk is relatively small, but we understand that there is theoretically some risk. PL hemorrhage, yes.
Max, in your case, was it like a low flow or high flow situation?
It was basically like, it was a sigmoid fistula, pretty high flow. The PL supply was kind of almost like an aneurysm on it. Like there was like, so like the PL supply was kind of prominent in there, and it looked like a little bit more, I don't know, concerning in retrospect. Like we have typically we do like we probably would have just gone ahead and closed this and taken the risk. Just like close the sinus with coils or something, but the rest of it, but I agree, like I totally agree that like what's the problem with doing what you did? You know, if the pulsatile tinnitus is tolerable, then you know the question would be if it continues to grow or something, at what point we
Yeah, I guess the
Stage.
problem is that it's still a nidus to recruit vasculature, right?
Mm-hmm.
And that could lead to then a further more dangerous state. I don't
Okay,
know.
now let's throw back to Hidetsugu. Like, why not? Let's say it gets bigger. Can you operate on this? You can disconnect this thing surgically, no?
Well, probably yes, but I mean, I think it's quite difficult to approach. So I'm not sure. I mean, personally, I haven't done it before, so
But surgically, you would have the same problem unless you try to find these PL feeders and close them surgically as well. Otherwise, if the surgery for dural fistula is to close the vein, if you do that, you know, at the end of the day, you're going to have the same risk that we're discussing.
no, I mean, surgically, I think I can close, I mean, I can coagulate the PL feeder, right? First.
That's the thing. Like if you can get to the feeder selectively, surgically, close it, and then do whatever was, then you can finish it endovascularly, the vein.
Another question is that would you transarterially close the PL feeder?
If you can get into it, yes, but as you said, it's a little bit like maybe it will grow and then it'll be
In this
easier to
case, yes.
catheterize, but seems a little flimsy now. It's not a right.
Yeah.
This was like a corticus, a much smaller artery that I think like just grew up to be what it is now. So
I think, yeah, whatever risk that would involve going transarterial would be, in my mind, higher than just transvenously taking down the jugular bulb. But, you know, what do I know?
Yeah.
it's a obviously interesting case.
Thank you.
Yeah. How when did you how long follow-up do you have on this?
Well, just for 1 year, and the fistula doesn't change at all, so I'm just following.
You can see that very well in the MRA, right? So if it were to,
Yeah.
but clinically, probably the sound,
The tinnitus is the same.
another factor.
Yeah.
I mean, the tinnitus is cured now. She doesn't have
Not
the
cured.
tinnitus.
It's not cured. It's almost, it's,
No,
it's
it's
better.
not.
It's better.
Yeah. You want to close it?
It seems like, though, that if you're going to go, you know, if you're doing transvenous for these PO ones, there are probably high risk features. Like you said, there's some kind of aneurysmal component on it, or in high flow states, it might be more risky. And doing it in a staged manner may help mitigate some of the risk. But I don't know.
That's possible.
I guess, I mean, from what it sounds like, I think most people would be willing to go ahead and finish it. But
Yeah.
but we're saying it for your patient.
Yeah.
It's so it's a little bit
So let's see.
I don't disagree with what you did, really. Like it's conservative, it's effective for the stage, Labey's
It's
out
great.
of the
I mean,
equation.
You always
it.
have the option to treat again if you want, right? So you can do it if you need to, and you don't have, you know, you don't have to go for broke for sure.
I want to keep following, and then let's see what happens.
Thank you. Okay.
Thank you very much.
Thank you. Now there was some questions about, like, let's see what's on the chat. There were some questions about how to do the dyna. We have some papers on that, and I think we'll have the banana too, like in terms of the imaging. Anything else? Any other questions, comments?
There was a a comment from Hamed. If you're there, you know, you can just unmute yourself, but he's saying sometimes occlude the distal occipital and then pressure cooker from more proximal to the point of occlusion to get, you know, retrograde feeling dangerous feeders as well. Keeping a vertebral control in place. But yeah, I think, you know, Hidetsugu mentioned that, you know, he didn't want to do this to avoid the risk of embolization of the vasa nervorum. I think that's why he didn't want to do this.
Hello, Eytan. Sorry, can you hear me?
Yeah.
Sorry, I'm not sure about at the time I was watching on my phone, to be honest. I couldn't see the image very well, but I thought there was decent amount of feeders coming off from the second or third portion of the occipital artery into that foot plate, just proximal to the vein of Lebey. And I think as long as you have control over the periatlantal collaterals into the vertebral, it's actually quite safe in injecting into the occipital artery. Getting control proximally sometimes is difficult, but with coiling glue, or if you have a very long balloon, you normally get enough seal that you get a good push, and it goes and blocks off the foot plate. And then if it goes to the dangerous feeders like the PL1 retrogradely, that's a bonus. If it doesn't, you've killed the foot plate anyway. You've cured it. And if you are very conservative, you can have a venous balloon at the same time as well. We've done quite a bit with the occipital artery, and I have to say that we found it very safe as long as you don't get problem proximally or getting reflux into the vertebral. The branches of the occipital itself is actually quite safe.
So, okay, from that perspective, I have to say I feel similar like you. Like, you know, we've done quite a few, like in this region, never had a nerve problem, or not that I remember. But, you know, anatomically, the concept is that, you know, the fistula here is very proximal. It's almost at the at the bulb, the more proximal part of the fistula. So if you, from the occipital, if you want to cure those, you will have to push enough, like enough in order to get to the region of the jugular foramen, like, or very close to that. So the risk theoretically is there. You know, but I'm translating Hidetsugu concern, because I agree with you. I would have also probably do something similar.
Hamed, I think, I don't know if you saw, like, I think it seemed like there were a couple of areas of, like, there was an occipital supply, but there was an area of fistula by the bulb. So it might be like more proximal than the ones where the occipital, I think, works, as you said, are a little bit more distal, maybe. At least that's where the occipital is safe. And that's where the petrosquamosal branch of the MMA is also great, because it goes to that similar area often, and either from there or from the occipital, like, get to a really nice spot.
Right.
Thank you.
Okay, anything else? Okay, any other? Okay, there's no other questions, comments. Then want to thank everybody for joining, of course, and participating. I think we had a really nice discussion. The cases were fantastic. Another, like, I think another great banana session, if I have to say. But we are excited for the banana. We'll figure out the next bananas. Keep you posted on when the next online one will be. And great to see you all. Please contribute cases. Let's talk. Anybody else want anything to say?
Thank you, Max.
Thanks, Max.
Okay.
Thanks, Eytan. Carlos Alcaraz won. So
All right.
that's a him.
Thank you all. We'll
Thank
see you
Great
soon.
discussions.
Good discussions.
Thanks everyone for joining.
Thank you, everybody. Thank you very much.
Thank you.
Yeah.